A head CT taken on a spring evening in a community emergency department. Bilateral bifrontal intraparenchymal hemorrhages. The left hemorrhage measured roughly 4 by 8 centimeters. The right about 4 by 4. Edema surrounding both. And a patient who walked into the ED with a friend, complaining of a headache. Glasgow Coma Scale 15. Oriented, answering questions. Abrasions next to one eye, dirt on her clothing, no memory of what had happened. The on-call neurosurgeon reviewed the images remotely. He decided the patient was in no imminent danger. He did not come to the hospital. He did not write a note. His physician assistant, briefed by phone, entered the orders, but also did not write a note. The clinical reasoning that would eventually anchor a 7-figure settlement existed at that moment, only inside one physician's head.
Welcome to On the Record. I am Michael, joined as always by Brian and Sarah. This is Case 8, and this episode is a case we are calling No Note, No Defense.
The Charted Defense is an educational program for physicians and clinicians. It is not a law firm, and nothing in this episode constitutes legal advice or medical advice. Laws governing medical practice and malpractice vary by jurisdiction, and physicians should consult qualified legal counsel for guidance specific to their state and situation. Case details discussed are drawn from publicly available court records, published opinions, and peer-reviewed sources. Where appropriate, patient, physician, and institutional identifiers have been anonymized. The views expressed by the host reflect clinical and educational perspective, not advocacy for any party.
This is a case that resolved before trial, so there is no verdict. There is a record, thousands of pages of depositions, expert affidavits, motion practice, and a summary judgment decision. And there is a settlement. The question I want to come back to around 70 minutes from now is what we can take away from this case. What patterns, what habits, what questions to carry to the next shift.
The patient was a college student. By every account in the record, she was healthy. She was active. She had no chronic medical conditions and no prescription medications listed in the hospital's admission data. On the evening of her presentation, she walked into a community emergency department late in the evening with a friend. The triage note read, "Patient presents to the ED. Complaint of head injury. Status post, fall down a hill." The patient herself said she was unsure exactly what had happened, but thought she had fallen down a hill the night before. She had abrasions next to her left eye and on her face. There was dirt on her clothing. She had no recollection of the events leading up to the fall or after it. Her Glasgow Coma Scale was 15. She rated her pain 5 out of 10. She denied alcohol or drug use. Her urine toxicology screen was negative. Her blood alcohol level was negative. Her urine pregnancy test was negative. There were no focal neurological deficits on the emergency physician's exam. There were, however, 2 complications embedded in that otherwise reassuring presentation. The timing of the fall was unclear. One version of the history put it in the prior 21 to 24 hours. Another version, based on the roommate's account, put it at 48 to 72 hours. The roommates had assumed the headache was a migraine and had not brought her in. The mechanism itself was also unclear. There were no witnesses. The patient could not recall. The emergency physician tried to reconcile the picture on her own, in real time. In a signed statement to police, she wrote that this was a highly unusual presentation of a young person with a head injury, and that, at this time, it is unclear what mechanism could have led to the devastating injuries. At her deposition, she was asked what she had meant. She testified that she would typically expect more overt external signs of trauma given the degree of intracranial injury the patient had suffered, and that, given the severity of the head injury, it did seem unusual that there were limited external signs of trauma.
This is the clinical first impression, and it is worth taking carefully. If you just look at the patient, GCS-15, walking, talking, answering questions, you might think, fine, a headache, a fall, a concussion at worst. There are clues embedded in this presentation that should give every clinician a moment of pause. Dirt on her clothing, abrasions next to her eye, no memory of what happened. A potential non-displaced orbital fracture on her first CT. Something real happened to her. Something real enough to cause bilateral bifrontal hemorrhages. And the patient in front of you does not look like the patient you would expect to see with those scans. There is a baseline question in there too, and it is one the treating team was asking. Her friend said she was answering slowly and answered no to many questions, but otherwise seemed alert and able to engage. So there is a legitimate question. Was she acting normally for her, or was she subtly off from her baseline in a way only people who knew her would catch? That is hard to elicit in an ED, but it matters. Subtle deviation from baseline in a patient with bilateral intracranial hemorrhages is not reassuring. The discrepancy, a scan that does not match the patient, can be one of the more dangerous moments in emergency medicine, not because something needs to be done in the next 5 minutes, because the differential diagnosis is wider than the history suggests, and everything you do over the next few hours is built on whatever hypothesis you choose now. If your differential is narrow, you can miss the life-threatening cause of what is actually an impending medical emergency.
The emergency physician ordered a stat head CT and cervical spine CT on arrival. The head CT, performed about 45 minutes later, showed acute bifrontal hemorrhages, left larger than right, with surrounding edema. There was no midline shift. There was no mass effect on the cistern around the pons and midbrain. There was a question of an undisplaced fracture along the lateral wall of the left orbit. The emergency physician consulted neurosurgery. The on-call coverage was structured as a neurosurgery attending paired with a physician assistant. Both were at home that night. The physician assistant reviewed the records. The attending reviewed the CT remotely. The plan they arrived at was communicated by phone. The PEA entered a series of orders into the chart. Those orders were: admit to the intensive care unit under the intensivist service, neurological checks and vital signs every hour, continuous 3% hypertonic saline, clevidipine for blood pressure control, strict intake and output monitoring, and continuation of the levetiracetam, brand name Keppra, that the ED had already started. Neither the attending neurosurgeon nor the PA came to the hospital. Neither of them physically examined the patient, and neither of them wrote a narrative note. The PA later testified that his documentation was, in his words, strictly limited to entering medical orders into the electronic medical record. The attending later testified, under oath, I did not write any personal note on the 8th, no.
The first teaching point of this episode sits right here in the first 3 hours of the patient's admission. The standards for when a consulting specialist must come in and the timeframes required can differ by hospital. Every institution has its own medical staff bylaws, its own consultation policies, and its own expectations around what a phone consult looks like. Some allow remote evaluation for stable patients. Others require an in-person evaluation within a specific window. If you're a hospitalist or an emergency physician, you need to know what your institution requires. And you need to know that the answer is not necessarily the same at the hospital down the road. The second thing I would say is this. If you have concerns that this patient might need an in-person evaluation, speak up. Tell the specialist you think they need to see the patient. Sometimes our description of the event, the way we relay information over the phone, may not tell the whole story. Sometimes it might accidentally provide reassuring information that leads the specialist to conclude the patient is stable for now. That is a judgment call, and it is a call that the bedside clinician has to make actively, not passively. And there is a liability dimension to this that I want to name directly. As the intensivist, the attending accepting this patient, you are the physician of record. If some neurosurgical emergency develops overnight, you have some liability exposure. So I would be quick to call and request that they see the patient. That is just my recommendation. It is a protective step for the patient and a protective step for you.
And on the documentation side, a specialist consultation note is not a procedural formality. It is the narrative that allows the next shift and every shift after that to know what the consulting specialist saw, what they thought, what they planned, and, critically, what specific clinical changes should prompt re-contact. Orders without narrative are not a consultation. They are a list of instructions. The reasoning is not in the chart.
Which matters both at the bedside and 4 years later, when someone is being asked to reconstruct their thinking at a deposition table.
The patient was transferred from the ED to the ICU late that night. The timing of that transfer appears in the electronic record as around 1:30 in the morning. There is a disputed fact embedded in the transfer. The electronic medical record logged what the system called an added end time on the hypertonic saline infusion at the moment of transfer. On its face, that looked like the infusion was stopped. The defense position, supported by the medication administration record and by the receiving ICU nurse's sworn testimony, was that the infusion was not clinically stopped. It ran continuously through the morning and into the afternoon of the next day. The plaintiff's position was that the infusion was in fact stopped at the time of transfer and never restarted until much later. The record supports both sides in different places, and we will come back to it. At 6 in the morning, the off-going night nurse performed a neurological check. At 6:30, the documented vital signs included an oxygen saturation of 80%. At 7, the incoming nurse arrived, and the two nurses performed a joint neurological assessment. The patient was slow to respond. She could not state the month. The shift handoff was verbal. The incoming nurse wrote key information on her personal report sheet, which was shredded at the end of her shift per routine practice. The only surviving documentation of what was communicated between nurses is what ended up in the time-stamped electronic entries.
A few things to flag here. The oxygen saturation of 80% at 6:30 in the morning is a significant finding in a patient with bilateral intracranial hemorrhages. In a normal healthy adult, that is hypoxia. In a patient with a brain injury, it is hypoxia layered onto a brain that cannot tolerate hypoxia well. The chart does not document what happened in response to that number. Maybe it was an artifact. Maybe the probe was off. Maybe it's self-resolved. Maybe someone addressed it verbally. What we have in the record is a number with no narrative attached. That is a pattern worth noticing. Vital signs without commentary are data without interpretation. If a number is low and real, document what you did. If a number is an artifact, document that too. The chart should not leave the next clinician, the next shift, or the next reviewer, whoever that is, wondering whether anyone saw it. The second point is about the handoff. Nursing handoff is a clinical process. A verbal handoff can be excellent, and in real practice, most of them are. But when the written artifact is destroyed by routine, the only evidence that specific information was communicated is what happens next. If the incoming nurse acts on a finding, we can infer the handoff covered it. If nothing happens, we cannot tell whether the finding was communicated at all, and this is aimed at nursing colleagues as much as physicians. An electronic handoff tool or a structured SBAR with a permanent record is a place where team communication becomes team documentation. The structure of every shift change is its own microsystem, and systems with permanent records are easier to defend later.
At around 8 in the morning, the neurosurgery attending arrived at the hospital for the first in-person evaluation. He came to the ICU with the physician assistant. The PA, acting as scribe for the attending, documented the physical exam. The note included the line, "Decreased motion in the left upper extremity." That finding, a new lateralizing motor deficit in a patient who had presented the night before with no focal deficits, was a new finding. The note was entered and the attending co-signed it. The attending later testified under oath that when he had personally examined the patient, his exam was, in his words, totally normal, and that she was perfectly fine. He testified that he believed the PA's finding could be attributable to the patient not putting forth full effort or to an unwitnessed seizure. No addendum or clarification was entered into the chart to document this disagreement. The nurse on shift had documented, independently, that the patient's right hand grip was stronger than her left, and that her left was weaker. And although no escalation of the intracranial workup was ordered at that time, the weakness was not ignored. The neurosurgery physician assistant, at the attending neurosurgeon's direction, placed an order that morning for an MRI of the cervical spine, with the documented exam reason, left arm weakness pain. The intensivist's concern ran in parallel. Orders for shoulder and clavicle x-rays and maxillofacial imaging were entered around the same time, consistent with a workup for possible traumatic extremity or cervical spine injury from the fall. Both sets of orders acknowledged the left-sided weakness, but oriented it toward a traumatic rather than an intracranial etiology.
There are two separate issues here, and they are easy to conflate. The first is the clinical issue. A new lateralizing deficit in a patient with bilateral intracranial hemorrhages is a sentinel finding. It does not matter whether you attribute it to hemorrhage expansion, to evolving edema with mass effect, to an unwitnessed seizure, to a soft tissue or bony injury from the fall, or to something else. Every one of those explanations requires action, repeat imaging, reassessment of the surgical question. And if you disagree with your PA's exam, a documented disagreement with your reasoning for dismissing the intracranial differential. The second issue is a potential discrepancy between what the chart shows and what the neurosurgeon testified to years later. The chart is actually quite consistent in one direction. The PA's note documents decreased motion of the left upper extremity. The nurse's documentation supports that weaker left hand grip. The MRI of the cervical spine is ordered that morning for the left upper extremity weakness. And the attending neurosurgeon co-signed the PA's note the next day, acknowledging that workup for the left upper extremity weakness was in progress. That is a chart that tells one story. The deposition testimony tells a different story, that the exam was completely normal, that the attending re-examined the patient and found no deficits. This is a potential discrepancy that we have talked about in earlier episodes. The chart is consistent. The later testimony deviates from the chart, and a jury or a judge reviewing the record will weigh those differently than you think. When the record contradicts the testimony, the record tends to win.
And this is a moment where the documentation discipline we discussed earlier matters in reverse. If the attending believed the PA's exam was inaccurate based on his deposition, the time to document that was in the chart, at the time, with the reasoning. Patient examined, left upper extremity motion preserved. Discrepancy with prior PA note likely attributable to effort or whatever you think is causing it. No escalation indicated. 2 sentences, done. Without that, the only formal record of the exam is the PA's note that the attending co-signed, and co-signing a note is, legally and clinically, an endorsement of its content.
The teaching point here is not that the attending was wrong about his clinical call. He may have been right. The patient may have had some soft tissue or orthopedic injury limiting strength or some other process. She may have had a brief unwitnessed seizure. None of that is resolvable now. The teaching point is that the contradiction, chart says one thing, sworn testimony says another, is the kind of contradiction that does not help you in litigation. And the way to prevent it is documentation at the time of the encounter.
Between 8 and 10:30 that morning, the patient's neurological checks were documented as unchanged. Slow to respond, lethargic, following commands, moving all extremities, pupils equal and reactive. At 10:30, the family arrived in the ICU and the patient reported pain. Shortly after, she began striking the right side of her bed with her right hand. Her left hand was contracted. Her pupils were sluggish. The ICU nurse noted that her heart rate had increased and her blood pressure was fluctuating. The intensivist was notified. The neurosurgery PA was called. A stat head CT and CT angiogram were ordered. The MRI of the cervical spine that had been ordered hours earlier had still not been completed. There is a documentation artifact in that order that matters. The attending neurosurgeon directed a stat study, but the hospital requisition listed the priority as routine. The scan was performed at 11:31. The radiologist's read was finalized at 12:31, 1 hour later. The radiologist's official impression of the repeat head CT described extensive bilateral frontal hemorrhages, more extensive than the initial study, with new areas of hemorrhage in the left frontal lobe near the vertex and possibly on the right side. Associated edema in a pattern suggestive of bilateral frontal contusions. Mass effect bilaterally with effacement of the sulci. No clear midline shift. The CT angiogram read, documented that the arteries were patent, with no aneurysm greater than 5 millimeters and no arteriovenous malformation. The report did not mention any finding in the venous system. That omission became important to the litigation. Both experts who later reviewed the imaging, the plaintiff's radiology expert and the defense neuroradiology expert, agreed that a venous thrombosis of the sagittal sinus was visible on the CT angiogram. The hospital radiologist did not report it. No supplemental or amended report was ever issued. The electronic access records later showed that the attending neurosurgeon did not open the CT angiogram report until 2 hours after the scan. And roughly the same moment, the patient was sliding into an irreversible coma. Between 1 and 1:30 that afternoon, the patient developed recurrent focal seizures, decorticate posturing, and lapsed into coma.
Several things are layered into this segment, and they have to be separated. The imaging itself showed hemorrhage expansion. That part was correctly read. The edema was worse. The mass effect was worse. What was missed was the venous thrombosis on the CT angiogram. The diagnosis of cerebral venous sinus thrombosis on a non-contrast CT is hard. A dense sinus sign or a cord sign can suggest it, but the sensitivity is low, roughly 25 to 30% in most published data. CT angiography and CT venography are the appropriate studies. So if the CT angiogram showed the clot, that is where it should have been identified. And the findings on the repeat head CT itself deserve a second look in light of what we know now. Bilateral frontal hemorrhages, a new area of hemorrhage near the vertex, sulcal effacement without a strong arterial territory pattern. That combination is compatible with cerebral venous sinus thrombosis causing hemorrhagic venous infarction. Superior sagittal sinus thrombosis classically produces parasagittal, often bilateral hemorrhages with edema, and the pattern often does not respect a standard arterial territory. At the same time, the same 12-hour evolution is fully compatible with blossoming traumatic contusions, which commonly enlarge during the first several hours and into the first day. The fact that the radiologist described the edema as suggestive of bilateral frontal contusions means the morphology looked traumatic on that scan. The honest read is that the imaging is consistent with CVST evolution, but not specific for it, and trauma remains a strong competing explanation unless venous imaging shows otherwise. That misread matters, and we will come back to it. But the clinical team did receive new objective data from the CT angiogram to act on based on what the radiologist did report. The patient had hemorrhage expansion. She had worse edema. She was clinically deteriorating. That alone demands action. Repeat neurosurgical assessment, reevaluation of the surgical question, consideration of escalating ICP management. About the dexamethasone, the intensivist ordered dexamethasone during this window for cerebral edema. We can talk about whether that was the right call. The CRASH trial established that high-dose steroids in moderate to severe traumatic brain injury increase mortality. The Brain Trauma Foundation guidelines do not recommend steroids for TBI, but I do not think dexamethasone is the most important teaching issue here, in my opinion. In the setting of a rapidly deteriorating patient with a catastrophic event unfolding in front of the team, a single dose of dexamethasone ordered to temporize is not likely the inflection point of this case. But it is still worth noting. What matters more is two other things. One is the delay in reviewing the scan. 2 hours between scan completion and the ordering physician opening the report is a long time in a deteriorating patient. And it is compounded by the fact that the order, which was stat verbally, was logged as routine on the requisition. Different electronic systems handle priority differently, and some systems default ASAP and urgent into the routine queue. If you say stat and you need stat, check that the requisition says stat. Otherwise, you may be waiting on the processing queue without knowing it. 2 is the communication dimension. As the hospitalist or intensivist, you are the attending. You are at the bedside more than the consulting neurosurgeon. You have the most information about what has changed clinically. If you see the repeat scan and you see worsening, or if the patient's clinical course diverges from what the specialist was told, document that you communicated it to neurosurgery. Because if a case ever turns on who knew what and when, that documentation is the record that protects the bedside team. Always remember, we are the advocate for the patient.
The patient was intubated for impending respiratory failure in the early afternoon. A brain MRI was ordered and performed in mid-afternoon. The formal read described bilateral hemorrhagic contusions, right up to 7 centimeters, left up to 6, with extensive positive mass effect, extensive subarachnoid blood product, possible thin bilateral subdural hematomas, partial effacement around the pons and midbrain, consistent with early uncal herniation, tonsillar herniation, the cerebellar tonsils 3 millimeters below the foramen magnum, an evolving infarct in the distribution of the left posterior cerebral artery. Bilateral watershed hemorrhagic infarcts, possibly related to global ischemia. The formal MRI report did not mention sagittal sinus thrombosis. The neurosurgeon's own progress note after the MRI documented massive and multiple bilateral contusions, increasing edema, and tonsillar herniation, shear injuries and pending stroke along the left posterior cerebral artery. 2 days later, after the patient's sister had raised the possibility that she had been taking oral contraceptives, and after a CT angiogram done as part of the brain death workup had shown no supratentorial cerebral blood flow, the same physician authored a progress note stating that sagittal sinus thrombosis cannot be excluded on MRI and CTA. The context for that line is important. With no supratentorial flow on the brain death CTA, a new venous thrombosis could not be ruled out on that study. and the sister's report had put OCP-related thrombosis on the differential. Unfortunately, too late to alter the course for this patient. Nursing contacted neurosurgery twice in the hour after the MRI. The attending neurosurgeon decided to place a ventriculostomy. The procedure was performed around 6 in the evening. The opening pressure was 30 to 35 millimeters of mercury. 25 to 30 milliliters of cerebrospinal fluid and hemorrhagic fluid were drained. The attending characterized the pressure at deposition as only slightly elevated, only in the low 30s. The catheter dislodged and was revised. The revised opening pressure was 40 to 45 millimeters of mercury. At that point, the patient had been comatose for several hours, with a Glasgow Coma Scale of 4, fixed and dilated pupils, and intermittent decerebrate posturing. The consent for decompressive craniectomy is disputed. The patient's father testified that a physician explained the need to remove the skull and that he signed consent late that morning, between 11 and noon. The attending neurosurgeon testified that the consent was signed close to midnight. The father also testified that around 10:30, 11 at night, they said that the surgery needs to be performed now. Anesthesia began just after midnight the next morning.
There is a lot to pull out of this afternoon. The ventriculostomy opening pressure of 30 to 35 millimeters of mercury is not slightly elevated. The Brain Trauma Foundation threshold for treatment is 22. The threshold used for randomization in the Rescue ICP trial, the landmark Rescue Decompressive Craniectomy trial, was 25. A pressure in the low 30s is significantly above both thresholds. After the catheter revision, a pressure of 40 to 45 is severely elevated, not minimally. Language matters here. If there is a clear scale and you describe findings in terms that do not match the scale, that discrepancy is a teaching point for deposition preparation. Be accurate with terms of degree. If the number is 32, it is in the range that triggered trial randomization. That is not slight. Second, the MRI timing. The brain MRI was what clarified the picture. Tonsillar herniation, evolving infarct, worsening edema. Earlier MRI might have altered the decision point. That is a real question, and I do not want to pretend it has a simple answer. MRI is a longer study. It tends to have more delays in ordering and acquisition than CT, which means that when you have a concern in the morning and you anticipate that care decisions will depend on MRI findings, that is the time to push to expedite it. Make it unambiguous that this is a study that drives a decision, not a study that is added to the work list. The CT angiogram in the interim was helpful in escalating the concern, but it did not answer the questions that the MRI answered, and by the time the MRI was read, the clinical window was closing. And if the CT angiogram had accurately identified a cerebral venous sinus thrombosis, the treatment pathway would likely have been different. Third, the surgical timing, and specifically the consent question. The record has the father placing consent late morning. The attending places it near midnight. We do not have a way to resolve that dispute from the documents available to us, but we can observe that a 9 or 10-hour window between a patient having herniated clinically on fixed dilated pupils, deep coma, and decompressive craniectomy is a long window. Whether earlier surgery would have changed the outcome is itself a debated question, which we will return to when we talk about the experts. Finally, on the numbers themselves, the Rescue ICP data support that rescue decompressive craniectomy can reduce mortality even in late refractory elevation. It is not a universally futile intervention. Younger patients do better, but a rescue craniectomy also shifts more survivors into severe disability. This patient, by the time surgery began, had been comatose with fixed dilated pupils for many hours. The prognosis at that point was catastrophic by most measures. The literature does not support an absolute futility threshold, but it does support that the prognosis was poor regardless of what happened at midnight.
The patient did not regain neurological function at any point after surgery. She developed diabetes insipidus and required vasopressin analog. She required transfusions for anemia. Her Glasgow Coma scale remained at 3. Pupils fixed and dilated. No response to pain. No corneal reflex. Not breathing over the ventilator. Brain death testing was initiated that evening, but could not be completed immediately because the patient's core temperature was below the protocol threshold of 96.8 degrees Fahrenheit. After warming, a full brain death checklist was completed by the neurologist. Coma, cause known, irreversible. Normothermia restored. Systolic blood pressure adequate. Pupils non-reactive. Corneal reflex absent. Oculocephalic and oculovestibular reflexes absent. No motor response to noxious stimuli. Apnea test positive with a carbon dioxide level of 61. Ancillary CT angiogram confirming no cerebral blood flow. Brain death was declared at around 10 that evening, roughly 48 hours after the patient had walked into the emergency department. Physical death followed extubation about a week later. Within months, the family filed a lawsuit. And the question that would consume the next 4 years, the question that would eventually resolve for over $1 million, was not whether anyone meant harm. It was whether the care was delivered in time, and whether anyone documented what they were thinking.
2 observations before we move to the legal side. The first is that we do not have the complete medical record. What we have is what was filed in discovery and what was quoted in depositions. That means we do not know how many times physicians came by to reassess this patient. We do not know everything the nursing team observed. We do not know what conversations happened at the bedside that were never charted. Some of what was absent from the chart may have happened. It simply did not make it into the record. That is part of the lesson. If we do not have the note, we do not have the encounter. I'm going to advocate throughout this episode for a very specific discipline. When you come by and reassess a patient with active changes in status, write a brief addendum. It does not have to be long, a line, 2 sentences. You do not have to rewrite the assessment. You just have to document that you were there, what you saw, and what you decided. If the care was good, that note will reflect it. If the care turns out to be a teaching case years later, that note is the evidence that you were engaged. The second observation is about the subsequent neurosurgery documentation, which I do want to credit. Once the deterioration began, the attending neurosurgeon did write progress notes documenting the evolving picture. An afternoon note capturing the decerebrate posturing, the autonomic instability, the suspicion of diencephalic seizures, and the plan for EEG, intubation, and MRI. A later note documenting the catastrophic MRI findings, the Glasgow Coma scale of 4, the family discussion around a grave prognosis, and the rationale for ICP monitoring. These notes exist. They capture what was happening. They are what the record should look like in an evolving emergency. Time-stamped, specific, clinically honest. The initial gap on the night of admission is a real point of concern, and it shapes the record in ways that will matter later in the litigation. But I want to name where I think the bigger clinical problem is. The bigger problem from the second day is the delay in surgical intervention after signs of impending and then active herniation were already visible. Documentation is necessary. The note is how we make our reasoning visible. But documentation alone does not save a patient. You also have to know when to intervene. And that is the part of this case where the clinical stakes were highest.
Within months of the patient's death, the family filed a medical malpractice and wrongful death action in state court. 14 defendants were named, among them the on-call neurosurgeon, the emergency physician, the intensivist, the neurologist, the neurosurgery director, 2 physician assistants, and several corporate entities affiliated with the hospital and the neurosurgical group. The core allegations were that the defendants failed to timely and properly examine, test, and diagnose the patient's condition, that they failed to appropriately administer or manage medications for cerebral edema, including hypertonic saline, mannitol, and dexamethasone, and that the director of neurosurgery engaged in negligent supervision by allowing a physician assistant to respond to an emergency trauma call rather than the attending physically evaluating the patient. The damages claimed were conscious pain and suffering, mental anguish, and wrongful death.
A few words on what a medical malpractice complaint actually is, in plain terms. A malpractice claim has 4 elements: duty, that the physician had a doctor-patient relationship creating a duty of care; breach, that the physician departed from the accepted standard of medical practice; causation, that the breach caused harm; and damages, that the harm is legally compensable. Breach is usually expressed as departures from accepted standards of medical practice. That is a phrase you will see in every complaint. It is a legal framing, not a clinical judgment. It means the plaintiff is alleging that a reasonably skilled physician in the same specialty would have done something different. Causation, in most jurisdictions, combines 2 concepts. But for causation, would the harm have happened anyway? And substantial factor causation, did the breach contribute substantially to the outcome, even if it was not the sole cause? In a case like this, where multiple physicians are involved in the care, substantial factor reasoning allows plaintiffs to argue that multiple departures together caused the harm, even if no single departure would have alone. And why 14 defendants? Plaintiffs typically name broadly at the outset for 2 reasons. One is preservation. The statute of limitations for adding a defendant is narrower than the period for discovering who may bear responsibility. 2 is leverage in discovery. Naming a defendant gives plaintiffs the right to depose them. Most named defendants in a complex medical case will not be the focus at trial, but they have to be named early to remain available later.
Discovery in this case spanned more than a year and included depositions of the treating physicians, the physician assistants, the nurses, and members of the patient's family. Several of the depositions produced testimony that would shape the summary judgment decisions and ultimately the settlement posture. The attending neurosurgeon admitted directly that he did not write a note on the night of the patient's admission. Under his group's practice, he explained, a note would have been written only if a member of the neurosurgical team had physically come to the ED. Since he reviewed the CT remotely and communicated the plan through his PA, the plan was captured in the PA's orders, and there was no narrative note from either of them. The intensivists' dictated history and physical included 5 transcription blanks. Some were contextually minor. Others, including one in the line about the type of hemorrhage and one in the line about the duration of the headache before presentation, were more clinically significant. The entire physical examination section was also absent from the dictated note. At deposition, the intensivist acknowledged this. He said, in his words, "It is obvious we have to fill the blanks, but sometimes it's omitted. And regarding the missing exam, it is omitted here. I don't see in my dictation. That is a typographical omission. I don't know how it is lost, but I don't see it here." The director of neurosurgery distanced himself from the attending neurosurgeon's employment structure and from any supervisory role. He testified, "I don't need to supervise an attending neurosurgeon." And later, referring to the attending, "I wouldn't consider him, again, a colleague." The physician assistant who was called to the ED on the night of admission confirmed that he had not written a narrative consultation note. When asked whether he had entered anything beyond medical orders, he answered, "No."
One legal point worth explaining because it came up repeatedly in the depositions. When plaintiff's counsel attempted to ask the director of neurosurgery questions about the standard of care, whether it was acceptable for a neurosurgeon to review films remotely, whether the attending was required to be available to operate, Defense counsel objected under what is sometimes called the Carvalho rule. That rule, in its essence, prohibits plaintiff's counsel from forcing one defendant physician to provide expert opinion testimony about a co-defendant physician's standard of care. The rule exists because a defendant physician is a fact witness. They can testify to what they did, what they observed, and what they thought. They are not an expert witness, disclosed in advance, retained to opine on another physician's care.
A treating physician can testify as a fact witness about what they saw, diagnosed, and did for the patient. Once the testimony shifts into professional opinions, especially causation, prognosis, or another physician's standard of care, it is usually expert testimony rather than ordinary fact testimony. In many cases, that testimony is still allowed from a treating physician, but only if the case lawyers have disclosed the physician under the applicable expert witness rules. In a deposition, if you are asked to judge another clinician's standard of care, that is a signal to slow down and look to counsel. Counsel may object, but unless privilege or a court order is involved, the usual rule is that the testimony proceeds subject to objection. If you are sitting in a deposition and you are being asked about another physician's standard of care, pause. That is often exactly the moment your counsel will object and instruct you not to answer.
Exactly. And the reason the objection matters here is strategic. If plaintiffs had been allowed to force the director of neurosurgery to testify that the attending should have come in, they would have had a defendant physician establishing a standard of care violation in the co-defendant's care. That is testimony worth a lot at trial. The objection, whether or not the court ultimately sustained it, blocked that path.
The plaintiffs disclosed 2 retained experts whose opinions would shape the case. The first was a board-certified neurosurgeon who chaired the Department of Neurosurgery at a major academic medical center. His opinions were directed at the attending neurosurgeon's decisions over the 30 hours between admission and cranectomy. He opined that the attending neurosurgeon had deviated from the standard of care by failing to perform a timely decompressive craniectomy. He opined that the signs and symptoms of cerebral herniation were clearly visible on imaging and incompletely responsive to medical management. In his words, the attending failed to offer and perform a decompressive craniectomy at a time that such treatment had a high probability of being effective and life-saving. He identified a specific inflection point. The afternoon brain MRI, he opined, was the first opportunity to treat the patient so that she would have the opportunity to have the best possible recovery. Surgical decompression, he opined, was indicated and necessary at 5 p.m. The evening of the deterioration, about 7 hours before craniectomy began. He also identified departures in the care of the emergency physician, the physician assistants, the nursing team, and the director of neurosurgery. He opined that the ED physician should have arranged for a bedside evaluation by the on-call neurosurgeon or by the physician assistant in the ED. He opined that the PAs and nursing team deviated by failing to re-administer the hypertonic solution when the patient arrived at the ICU, and by failing to order, perform, and record sufficient and frequent bedside neurological examinations. He opined that the director of neurosurgery deviated by treating the patient as a consulting physician and then deferring the bedside evaluation to the attending.
The timeline this expert drew is the central clinical argument of the case and deserves an honest evaluation. The MRI in the afternoon showed tonsillar herniation. That is not in dispute. The question this expert is asking is whether decompressive craniectomy at 5 p.m., but about 2.5 hours after the MRI was read, would have changed the outcome in a patient who was already comatose with fixed dilated pupils. The rescue ICP trial is the relevant literature. It showed that rescue decompressive craniectomy can reduce mortality in patients with refractory ICP elevation. At 12 months, the proportion of survivors with moderate disability or better was higher in the surgical group than in the medical group, but the trial also showed that craniectomy shifts more survivors into the vegetative state or severe disability categories. So the survival benefit comes with a cost in quality of neurological recovery. Youth improves the odds. Younger patients consistently do better after rescue craniectomy, but youth does not normalize the odds. A young patient with bilateral fixed dilated pupils, Glasgow Coma Scale of 3 or 4, and hours of established herniation has a prognosis that is poor, regardless of the surgical decision. So, was earlier surgery indicated? Reasonable experts can disagree. The plaintiff's expert opined that 5 p.m. was the first meaningful opportunity. The defense opined that by the time of surgery, the patient was already clinically brain dead. Both positions have literature support. The teaching point I want to put here is slightly different. The question is not only whether the surgery should have been at 5 p.m., it is also whether earlier MRI might have changed the picture. An MRI is a longer study. It has more acquisition time than CT. So if you anticipate that care decisions will depend on MRI findings, that is the moment to call, to push for the slot, to make clear that the study is driving a decision and not just filling the work list. The morning discussion about left upper extremity weakness is where I would have wanted closer monitoring and potentially earlier advanced imaging. Whether that would have saved her life is unknowable. But the window in which it could have mattered closed sometime in the late morning.
The second retained plaintiff expert was an interventional radiologist, board certified in radiology, with fellowship training in interventional radiology and neurology. His opinion engaged directly with the imaging question. He agreed with the defense that a venous thrombosis in the sagittal sinus was visible on the repeat CT angiogram. But he disagreed about its cause and significance. His theory was that the trauma caused the initial hemorrhages and edema, and that the cerebral edema from the trauma mechanically compressed venous outflow, which caused blood to back up and form the sinus thrombus as a secondary phenomenon. The clot, in his opinion, was a byproduct of the swelling, not its cause. He anchored that opinion on a specific observation. He opined that post-craniotomy CT images showed the thrombosis had cleared spontaneously once decompression relieved the intracranial pressure. That, in his view, supported the theory that the clot was pressure-dependent and not a primary thrombotic event. On the surgical timing, he was more absolute than the plaintiff's neurosurgery expert. He opined that the midnight craniotomy was performed too late, because by that point, in his words, the patient was already clinically brain dead.
One thing worth flagging about this expert's clot cleared spontaneously claim, that is his interpretation, drawn from his review of the postoperative images. None of the official postoperative radiology or reports we have in the record mention the status of the sagittal sinus clot. So this is an expert opinion based on re-review of images, not an independently documented radiographic finding. There is a further complication with the claim the postoperative CT angiograms in the record were done as part of the brain death workup, and they showed no supratentorial cerebral blood flow. That is consistent with brain death and was part of how it was confirmed. But it also raises a question about the imaging the expert relied on. If there is no supratentorial flow on the postoperative CTA, then that study could not have been the study that demonstrated a patent cleared sagittal sinus, because the absence of flow above the tentorium would have precluded opacification of the sinus in the first place. Whether the expert was working from a different study or from a different interpretation of the same study is not resolvable from the record. That does not make the expert wrong. Expert re-review of images is a normal part of litigation, but the distinction is worth naming. A finding documented in an official radiology report at the time of the study has a different evidentiary weight than an expert's reread for a report. Both are admissible. They are weighed differently.
The attending neurosurgeon's defense was anchored on a retained neuroradiology expert, whose theory directly inverted the plaintiff's sequence. Her theory was that the patient had an undiagnosed anterior sagittal sinus thrombosis, arising from a hypercoagulable state induced by oral contraceptive use. That thrombosis, in her opinion, caused a venous ischemic event. The ischemic event, not a trip on a hillside, caused the fall. The fall produced the orbital fracture and the external abrasions. But the bilateral bifrontal hemorrhages, in her analysis, were venous infarctions evolving into hemorrhagic transformation, not traumatic contusions. This theory relied on a general medical framework that is well established in the literature. Combined hormonal contraceptive use increases the risk of cerebral venous sinus thrombosis roughly 5 to 7-fold across multiple meta-analyses. Bilateral parasagittal hemorrhages in a young woman on hormonal contraception fit a venous territory pattern. The 2024 American Heart Association scientific statement on cerebral venous thrombosis specifically notes that non-contrast CT alone is insufficient to exclude it.
The medicine behind the defense theory is real. Oral contraceptive-induced cerebral venous sinus thrombosis is a well-documented clinical entity. The relative risk figures, Aisha, roughly 5 to 7-fold, are replicated across multiple meta-analyses. Bilateral parasagittal hemorrhages in a young woman on hormonal contraception absolutely can be venous infarctions with secondary hemorrhage. That is one of the classic presentations. And a spontaneous thrombosis can, in a subset of cases, cause a syncopal event or a seizure that leads to a fall. That pattern is less common than headache-dominant CVST, but it is described in the literature. And as Brian laid out earlier, a non-contrast CT is not a great study to rule in or rule out cerebral venous sinus thrombosis. A dense sinus sign or a cord sign can suggest it, but the sensitivity is low. The diagnostic standard is CT venography, or MR venography. So the first CT on admission would not have been expected to definitively show or exclude this diagnosis. The question is whether the clinical picture triggered the thought, whether anyone said, what if this bilateral parasagittal pattern is venous, and whether venous imaging was then obtained. In this case, no one raised the question during active care, and it is worth asking why. You see a patient with abrasions, dirt on her clothing, a fall history, a potential orbital fracture, and a bilateral hemorrhage that is bifrontal on CT. The amount of abnormality on the initial imaging may itself have functioned as a distractor. The team was working very hard on an actively deteriorating patient with a lot of findings to address. It is easy to see how that picture looks like trauma. The question I would want to ask is, why does a normal, healthy young person have such a traumatic fall for no clear reason, and one that led to such a severe injury? A low-mechanism fall in a 20-year-old that produces bilateral frontal hemorrhages with edema is an uncommon outcome. Something about it warrants further investigation. A fall where the patient was unable to brace or protect herself might suggest a loss of consciousness, a seizure, a syncopal event, something that preceded the fall. Now, to the specifics of this case, the oral contraceptive use was not documented at admission. It was introduced later in the course when the patient's sister raised the possibility that her sister had been taking oral contraceptives. The initial CT did not show sagittal sinus thrombosis. Even the defense expert agreed there was no evidence of venous thrombosis on that first study. No treating physician contemporaneously suspected CVST. And the basic coagulation labs were not hypercoagulable. They leaned mildly toward a bleeding tendency. A hypercoagulable workup was not ordered until after brain death. Whether the defense theory is the right theory is not something we can settle from the record. I think the CVST theory is medically viable. The pattern fits, the risk factor fits, and the absence of diagnosis during active care does not prove it was not there. A non-contrast CT is not a reliable test to exclude venous thrombosis. The reason the theory did not anchor the litigation is not that it is scientifically wrong. It is that the plaintiffs never framed the case around missed CVST. Their bill of particulars focused on the timing of intervention after the deterioration, not on the initial diagnostic workup. So the CVST narrative only entered the case through the defense as a summary judgment theory. One more point. Whether the injury started as trauma or started as thrombosis might not even materially change the allegations about delay in intervention. Either way, traumatic hemorrhage with expanding edema or hemorrhagic venous infarction from CVST, the clinical picture was a patient in severe intracranial crisis who needed escalated evaluation and treatment. The mechanism question matters scientifically. It matters less in terms of whether the decisions made that day held up.
The attending neurosurgeon was not the only defendant to retain expert opinions. Each of the other named defendants retained expert support appropriate to their specialty. The emergency physician's defense was supported by a board-certified emergency medicine expert who opined that the ED care, ordering the appropriate imaging, promptly consulting neurosurgery, and relying on the consulting specialist's judgment for admission disposition, was within the standard of care. The intensivist and the hospitalist were supported by a board-certified pulmonary and critical care expert who opined that their care, including the ventilator management, the deferral to neurosurgical expertise, and the medication orders, met the standard of care. The physician assistants were supported by a board-certified neurosurgery expert who opined that the PAs acted appropriately under attending direction within their scope of practice and did not make improper, independent clinical decisions. The neurologist was supported by a board-certified neurology expert who opined that the neurology care, treatment of active seizures, ordering of the brain MRI, and management of the seizure workup was appropriate, and that a neuroradiology consult was not required because the patient was already being followed by neurosurgery. The physician staffing company was supported by an additional emergency medicine expert who opined that reliance on the specialist's decision was standard practice for the ED physician.
The legal strategy here is worth naming. The defense in a case with many defendants was not one unified theory. It was a series of specialty-specific shields. Each defendant presented an expert focused on their own standard of care. Each expert stayed within their specialty and did not opine broadly on the overall management. This is a standard defensive posture in multi-defendant medical cases.
This is a theme we have talked about in other episodes. Multi-defendant medical cases are complicated. As a hospitalist, what I take from a case like this is the strategy Sarah just described. Every defendant needs to demonstrate that their specific area of responsibility met the standard of care. My job is not to defend the neurosurgical decisions or blame any other specialist involved. My job is to document that I communicated well with the neurosurgery team, that I documented the clinical changes I observed, that I escalated appropriately when findings warranted it, and that I did what was within my scope. As a hospitalist, in a case like this, there is really not much I can do to alter the outcome once the patient needs a surgical intervention that only the neurosurgeon can provide. I would hate to see the hospitalist held liable in that situation unless they failed to notify the right person, failed to consult appropriately, or missed something that was within their scope to act on. Documentation is how the hospitalist gets removed from a case like this. Communication is how the hospitalist gets removed from a case like this. The record should make it obvious that the hospitalist did what was within their power. And then there is a quality of practice dimension. Even if you are not going to be the defendant, you are still the patient's advocate. Push when you need to push. Ask for the in-person evaluation. Ask for the repeat imaging. Be the voice at the bedside, both for the patient and for the record.
A panel of summary judgment motions were filed by every defendant. The court considered them in a single consolidated decision about 3 years after the patient's death. The court granted summary judgment, meaning dismissal, for every defendant except the attending neurosurgeon. The emergency physician, the intensivist, the neurologist, the pulmonary critical care physician, the director of neurosurgery, both physician assistants, and the corporate staffing entity were all dismissed. The analysis for each was that the plaintiff's expert opinions either did not allege a specific departure within that defendant's scope of care, did not adequately allege causation, or did not rebut the defense expert's standard of care opinion. For the attending neurosurgeon, the court denied summary judgment. The court's analysis had 2 parts. First, the court found that the attending's expert, the defense neuroradiologist whose theory we just discussed, had not met the initial burden to demonstrate a prima facie case of no departure. The court found the oral contraceptive-induced thrombosis theory speculative and unsupported by, if not contradicted by, the medical records and other evidence. Second, even if the initial burden had been met, the court found that the plaintiff's experts had raised triable issues of material fact on the timing of the craniectomy, the standard of care, and causation.
Now, on the CVST theory itself, I want to be clear, for the record, that I think the OCP-related cerebral venous sinus thrombosis theory is medically viable. The science is there, the imaging signature fits, the risk factor profile fits. I would not have called it speculative on the science, but that is separate from whether the neurosurgeon should have been granted summary judgment. Even if the CVST theory were the exact right explanation for how this patient got to the hospital in the first place, it would not absolve the attending neurosurgeon from the allegations that survived. Those allegations are about the timing of intervention after the patient showed signs of impending and then active herniation. That is a triable question, and it is not answered by naming the initiating mechanism. If anything, a CVST framework raised during active care would have expanded the available interventions, additional imaging, neuroendovascular consultation, consideration of anticoagulation, not narrowed the question of whether decompression was timely. That path was never explored because the diagnosis was never considered, but the path existed. And the question the court was asked to decide is the right one, given the timing of recognition and surgical intervention. Is there a triable dispute? The answer is yes.
A brief note on what summary judgment actually means, in case this is new for some listeners. On a motion for summary judgment, the judge is not deciding which side is right on the medical facts. The judge is deciding whether the facts, viewed in the light most favorable to the non-moving party, create a triable issue, whether a reasonable jury could find for the plaintiff. The defendant moving for summary judgment has the initial burden to show there is no triable issue. If they meet it, the plaintiff has to come forward with evidence creating a dispute. The OCP-related CVST theory, as a matter of medicine, is defensible, but the court's ruling was about the legal sufficiency of the defense's summary judgment burden on the allegations that actually survived, the timing of surgical intervention after signs of herniation. On that question, the court correctly concluded that competing expert testimony raised a triable issue. That is the right call, regardless of which etiology for the hemorrhage eventually persuades a fact finder.
The case settled about 7 months after the summary judgment ruling. The total settlement was in the low 7-figure range, apportioned between the attending neurosurgeon and the hospital. The parties agreed to take no appeal on the summary judgment decisions. Attorneys' fees and costs were approved by the court. A stipulation of discontinuance was filed as to all defendants later that summer.
The apportionment of a settlement like this tells you something about how the parties read the risk. The attending neurosurgeon's exposure was significantly larger than the hospital's. That reflects the posture going into trial. He was alone. The other individual defendants had been dismissed. He was facing a plaintiff's expert, who was the department chair at a major academic neurosurgery program. The causation theory advanced by his own defense expert had been characterized by the court as speculative. And the operative questions, timing, standard of care, documentation gaps, were going to be presented to a jury in a trial that was likely to feature extended testimony about the hours the patient spent deteriorating without an attending neurosurgeon at the bedside. The hospital's exposure was smaller because it was primarily vicarious, tied to the actions of employees and agents, most of whom had been dismissed on summary judgment. With the direct claims narrowed, the hospital's trial exposure was narrower too, and the settlement reflects that. A pre-trial settlement in this posture is a defense calculation about trial risk. It is not an admission of wrongdoing. Settlements happen for many reasons: litigation cost, the emotional burden of trial on the family and on the defendants, the uncertainty of any jury verdict. The numerical split gives you a rough sense of where the parties thought the exposure lived. It does not tell you anything definitive about what a jury would have done.
There is one piece of this case worth returning to. The radiologist who read the CT angiogram and did not report the venous thrombosis. The radiologist was named in the initial complaint. He was never deposed. Early in discovery, plaintiff's counsel signaled in a letter to the defense and the court that the plaintiffs were reserving the misread theory pending review by their own neuroradiology expert, and that if no misread was identified, they would discontinue the claims against the radiologists. After that review, the plaintiffs abandoned the misread theory. Neither of their retained experts identified the radiologist's failure to report the sinus thrombosis as a specific departure. The radiologist was ultimately dismissed. The plaintiff's interventional radiology expert actually used the misread to support his theory. His argument, in essence, was that if no one reading the images at the time had identified the clot as medically significant, that itself was evidence the clot was not clinically significant, just a pressure-dependent byproduct of the edema.
A few facts to lay down before I offer perspective. No treating provider discussed or suspected sagittal sinus thrombosis during the active care. The diagnosis was first raised in a progress note the next day after the patient was already comatose. Before that, no one, not the neurosurgeon, not the intensivist, not the hospitalist, not the neurologist, not any nurse, had documented a concern for venous thrombosis. Both litigation experts years later agreed that the clot was visible on the repeat CT angiogram. But during the active care, the only people who had the imaging in front of them and the expertise to identify it were the hospital radiologist and likely the neurosurgeon. The radiologist did not report it. Everyone downstream was operating on his official read, which is to say, if the thrombosis was present and visible, it was a missed finding by the radiologist, and the other physicians reasonably acted on the report they had. Reading a CT angiogram for venous thrombosis is not in the scope of hospitalist practice, I would think. I personally would not know how to diagnose a cerebral venous sinus thrombosis on a CTA. I'm relying on the radiologist's read and on whatever the neurosurgeon tells me after they have reviewed the images. There is also a plaintiff strategy observation worth discussing. Going with a missed CVST theory could have introduced opportunities for the defendants to build stronger defenses, different experts, different causation arguments, a chance to argue that the diagnosis was difficult to make at the time, and that anticoagulation in a patient with hemorrhage would have been a hard call on its own. If that calculus was in the plaintiff's minds, missed CVST could have been a less attractive claim to pursue than surgical timing. It is worth raising because it speaks to how a single case can be framed in more than one way. The systems lesson is still there. The one objective, verifiable miss in this case, a finding both experts later agree was visible and not reported, was the one thing that never became a liability theory. If the thrombosis had been reported at the time at 12:31 in the afternoon when the read was finalized, the entire management trajectory could have changed, potentially a neuroendovascular consultation, potentially anticoagulation, even with hemorrhage, which is the current standard for CVST per the 2024 American Heart Association statement. Potentially a completely different framework for understanding what was happening. Whether any of that would have saved this patient's life is unknowable. She was already deteriorating rapidly by that point, but the option was never on the table because the finding was never communicated. The next 16 minutes are the reason I do this podcast. These are the things portable from this case to the next shift. One pillar of this case is documentation, not documentation as a legal defense. We will talk about that too, but documentation as the mechanism by which clinical reasoning becomes available to everyone else on the team. Start from the night of admission. The attending neurosurgeon reviewed the CT and formulated a plan. He had a rationale that the patient was in no imminent danger, that this was not a surgical issue, and that an ICP monitor was not indicated. That reasoning was clinically defensible in his judgment, but it was never written down. The ICU team that accepted the patient that night had a list of orders. They did not have a narrative explaining what the neurosurgeon had seen, what he had considered, what he expected, or what specific clinical changes should prompt recontact. Move forward to the morning. The PA documents left upper extremity weakness. The attending disagrees. The disagreement is never written in the chart. Years later at deposition, the attending says the exam was totally normal. The chart says something else. That is the kind of contradiction that does not help your case as a defendant. Move forward to the intensivists, admission history, and physical, blanks in the dictation. A missing physical exam offered at deposition as a typographical omission. That is the kind of gap that does not help either, especially if there is a claim that the patient had abnormal neurological findings during that time that your exam would have either confirmed or ruled out. And then the deeper point, which is the one that matters most. The same neurosurgeon whose deposition testimony about the morning exam contradicted all the available evidence in the record. Nursing documentation, the PA's note, the MRI ordered for the extremity weakness, that testimony likely did not help his case in any way. Even if he was completely accurate in his deposition, the jury could interpret his statements in the context of the medical record in front of them. And the record is the load-bearing part of the case. If the record contradicts the testimony, the record tends to win. Here is how to formulate it. The note is not paperwork. The note is the mechanism by which your clinical reasoning becomes available to the team caring for the patient at 3 in the morning, to the quality committee reviewing the case 6 months later, and to you sitting at a deposition table trying to reconstruct what you were thinking on a night 4 years ago. There is also a clinical dimension. Writing the note engages a different part of your thinking. When you pause to articulate your reasoning, you sometimes catch things you missed. Sometimes stopping to write down what you believe about a patient will itself give you the reason to further explore the possibility that you are wrong. That is a quieter benefit of documentation. It is not just a shield. It is a check on your own thinking.
And on the legal side, a narrative note is a very important piece of evidence a physician has in defending their care. Orders are a list of instructions. A narrative note is a record of thought.
The second teaching pillar is cognitive. Here is the cascade that runs underneath this case. Step 1, the chief complaint at triage, fall down a hill. That phrase on its own starts closing doors. It invokes a trauma schema. It triggers a trauma imaging bundle, non-contrast head CT in cervical spine. It could suppress the ordering of vascular imaging that would otherwise be on the differential. Step 2, anchoring on the mechanism. Once trauma is the working diagnosis, every subsequent finding is interpreted through that lens. A bilateral bifrontal hemorrhage becomes a pair of contusions rather than a possible venous infarction. An orbital abrasion becomes corroboration of the fall without triggering more discussion of why she fell. The mechanism may not fit the severity. A standing height fall in a healthy young college student rarely produces 4 by 8 centimeter hemorrhages, but that mismatch does not dislodge the anchor. Step 3, premature closure. The non-contrast CT shows hemorrhage. The trauma frame explains it. The workup closes. No additional vascular imaging was ordered in the ED. No CT angiogram, no CT venogram, no MR angiography or venography. The 2024 American Heart Association statement on cerebral venous thrombosis specifically notes that non-contrast CT alone is insufficient to exclude it, and additional vascular imaging is what broadens the differential in an atypical presentation. That step was the one that was missed at the front end. Step 4, missing risk factors. The patient's hormonal contraception was not on the admission medication list. Her parents did not believe she was taking any medications, and the question was only raised later in the hospitalization when her sister surfaced the possibility. So it is not fair to say the team dismissed an OCP risk factor. The risk factor was not available to them during the period that mattered, but the larger point still applies. When hormonal contraception appears on a young woman's medication list, or when the history leaves doubt about it, that could be a differential shaping fact when a 5 to 7-fold risk factor for cerebral venous sinus thrombosis, not a social history footnote. It should change the imaging you order, not just the counseling you provide. And even when you cannot confirm it, a young woman in the age range where hormonal contraception is common should be enough to keep a hypercoagulable etiology on your differential for an atypical intracranial hemorrhage. Step 5, catastrophe. The diagnosis matures only after the window for action has closed. The thrombosis is raised in a post-event progress note. The hypercoagulable workup is ordered after brain death. The teaching point to leave you with: a young patient with this level of intracranial injury without an obvious cause that looks proportionate to the imaging, a cause that does not match what you see in front of you, should make you pause. Not necessarily to diagnose cerebral venous sinus thrombosis, but to ask, could there be something underlying here beyond the reported mechanism? Could this be a thrombotic event in a young patient with a risk factor we have not yet elicited? At a minimum, ask what could produce this pattern on CT if we remove the fall as the assumed cause. That kind of pause can lead to additional emergent imaging. And this is where the case becomes portable. Remember this pattern. Remember this diagnosis when a patient walks in with bilateral frontal hemorrhages disproportionate to the mechanism and a scan that does not match the patient. File that image. Cerebral venous sinus thrombosis is rare and diagnostically difficult and life-threatening if missed. You may see this pattern once in a career. If you recognize it the next time, you might be able to change the outcome for a patient. The chief complaint is not neutral data. It is the first diagnostic hypothesis. When you write fall in the triage box, you have already started closing doors. The question every hospitalist should ask when they inherit a patient from the ED: what diagnosis would I be most afraid to miss? And has anyone explicitly ruled it out? And the larger question that ties this whole thread together: why did she fall? If the fall does not make sense, keep asking why. Something is not adding up here. Do not be satisfied with the diagnosis you inherited. Keep the differential open. A few minutes on the causation question itself, because it is worth engaging with, honestly. Both theories are medically legitimate. A traumatic brain injury with associated cerebral venous sinus thrombosis, where trauma comes first and the thrombosis develops secondarily, is a well-documented clinical entity. A spontaneous thrombosis related to hormonal contraception, where the thrombosis comes first and the fall is a consequence of seizure or syncope, is also a documented clinical entity. Both scenarios have been published in the literature. Both are real. What did I conclude about this specific case? I do not believe the evidence clearly favors trauma first. The OCP-related CVST theory is medically viable. A non-contrast CT cannot diagnose or exclude venous thrombosis. So the fact that the first CT did not show it does not tell us whether it was present. We know it was not seen on the first study. I am not sure I fully agree with the court on the characterization of the theory as speculative. The science is sound to me. The pattern reasonably fits. The evidentiary record during active care was thin because nobody was asking the question, not because the answer was unreachable. And when the CT angiogram showed a venous thrombosis that was not reported by the radiologist, that may have been the last meaningful opportunity to intervene before the window closed. Where I do agree with the court is on the legal outcome. The neurosurgeon's summary judgment motion was correctly denied. The triable issue is the timing of intervention after her neurological changes on the CT angiogram and MRI brain, and that issue does not go away whether the initiating mechanism was trauma or thrombosis. And here is a thought worth raising. An alternative framing could have been that the team failed to obtain vascular imaging when the non-contrast CT did not provide a plausible mechanism for bilateral bifrontal bleeds in a healthy young woman. That framing, a missed CVST on the initial workup, would have put the ED physician, the intensivist, and the radiologist squarely in the case. It might also have been a real opportunity to intervene earlier. I do not know whether plaintiffs considered and rejected that framing or whether they never developed it. But the point for a clinical audience is this. A single set of facts can be framed 2 or 3 different ways in litigation, and each framing pulls different clinicians into the center of the case. How the plaintiff tells the story determines who is on trial. What did not happen during the active care was anyone asking the question at all. No one considered the diagnosis, no one ordered vascular imaging, and that meant the treatment pathway, anticoagulation, neuroendovascular consultation, a different management framework, was never available because the diagnosis that would have triggered it was never made. 5 concrete things to take from this case to the next shift. 1. Write the note. If you are consulting by phone, document your assessment, your reasoning, and the specific triggers for recontact. Orders without narrative are not a consultation. 2 sentences can be the difference between a defensible chart and a chart that requires you to reconstruct your reasoning at a deposition table 4 years later. 2. When the scan does not match the mechanism, expand the differential. Bilateral hemorrhages in a 20-year-old after a low mechanism fall should trigger a question. The question is whether the mechanism could be more than just trauma. Could this be a thrombotic event in a young patient we have not yet fully characterized? At a minimum, pause and review what could cause this pattern on CT if we remove the fall. That pause leads to additional emergent imaging, and it might identify a diagnosis the initial trauma framework was never going to reach. 3. Consider hormonal contraception when the history leaves doubt. In this case, oral contraceptive use was never confirmed on the record. The parents did not know their daughter was taking any medications. The patient's sister raised the possibility during the hospitalization if a young woman with unexplained intracranial hemorrhage has hormonal contraception on her medication list, or if the history leaves a question, that could be a differential shaping fact. A 5 to 7-fold increase in cerebral venous sinus thrombosis risk. It should change the imaging you order, not just the counseling you provide at discharge. 4. Follow up on stat results. Do not assume the radiologist called. Do not assume the report will surface when you need it. For stat studies, call. Look at the images yourself within the limits of your training. 2 hours between a completed scan and a physician review of the result is 2 hours the team is operating without the data. And as the attending, the physician of record, be vigilant of pending results. Make sure the consulting specialist is aware of abnormal results as they come back. Close the loop. It is an increased burden of work. It may also be the difference between a good and a bad outcome. 5. Know the ICP thresholds and use the language accurately. This is less central for hospitalists, but the principle is portable. The Brain Trauma Foundation threshold for treatment is 22 millimeters of mercury. The rescue ICP randomization threshold is 25. A pressure of 30 or 35 is not slightly elevated. A pressure of 45 is not minimally elevated. If there is a clear scale and the evidence supports where a value falls on that scale, use language that tracks the evidence. Slightly elevated. In a situation where the number sits above the trigger for surgical trial randomization is a phrase that can be used against you. A plaintiff's attorney can turn that phrase into an argument that you did not recognize how dangerous the pressure was, and that your lack of recognition led to delayed intervention. Be precise with terms of degree. A final image before we close. A head CT taken on a spring evening. Bilateral frontal hemorrhages. A patient who walked into the emergency department and could not remember what had happened to her. And a team of providers who, over the next 30 hours, worked to make sense of what was in front of them. On the chart of defense, we go through these cases to learn. Like most of the cases we review, this one involves a complex and rare diagnosis on top of a rapidly evolving clinical picture. We are not here to blame a physician or a healthcare system for a bad outcome. We are here to take away everything we can from the case so that if any of us ever finds ourselves in a similar situation, we are ready. Thanks for listening. The public case name, the court, and the sources are in the episode notes. We will see you next time.
The Charted Defense is an educational program for physicians and clinicians. It is not a law firm, and nothing in this episode constitutes legal advice or medical advice. Laws governing medical practice and malpractice vary by jurisdiction, and physicians should consult qualified legal counsel for guidance specific to their state and situation. Case details discussed are drawn from publicly available court records, published opinions, and peer-reviewed sources. Where appropriate, patient, physician, and institutional identifiers have been anonymized. The views expressed by the host reflect clinical and educational perspective, not advocacy for any party.
Debate the sun, debate the bay, debate the golden story, debate the place, debate the boat, debate the scories whole, debate the leaves, debate the trees, debate the winter story. The wind is down, the wind is down, debate the seething sun, debate the sun. Debate the trees, debate the breezes glory, debate the sun, debate the dreams, debate the seething sun, debate the sun.